Hi, it's Elliot Fishman, and welcome to our latest Facebook Live. It's getting to the end of summer. I'm not sure what date today is, like the 23rd or so, or 22nd of August. And I hope everyone's end of summer is going well. It's amazing when I speak to some of my friends, and they have kids who are going back to school already. In California, the kids started elementary school about a week ago. So it's really, I'm trying to get some out of my pocket here. My phone is ringing, but it's amazing how the summer has passed. I think for the rest of us, the summer probably isn't that important. Though I did go away this past week with Sam and Max to a madhouse in New York, in the Highland, New York. And it was a lot of fun with the guys. Haven't been in the water that much in like 30 years. And I managed, indoor pools are wonderful, so you don't get too much sun. But it was a lot of fun. And now back working away. I was trying to, when Lily asked me what topic to pick, I thought, well, let's look at incidentalomas. I've been working on an upgrade of one of my talks for incidentalomas. And incidentalomas is always one of the most important topics when you speak at a meeting, and often one of the most controversial. And I say controversial, it's more in the management of incidentalomas and how people can deal with them. I think one of the things we've spoken about in the past is that you need to be able to really think about what's important as an incidental finding and what's not important. You can drive the clinicians crazy, and you can drive the patients crazy. You can get unnecessary follow-up studies, unnecessary biopsies. And the way I like to think about it is, you know, if you bought a Maserati, let's say, and you drove around Baltimore, you'd have a million dings probably within like a day. But, you know, if you have a new car, a year out is still pretty much a new car. You haven't been into an accident, hopefully. But, you know, there's little dings and dots and wears and tears and everything else. And that's the human spirit as well. You're born, you come in perfect condition, you grow up, and then you start falling apart on the way downhill. And hopefully your decline is not very sharp, and hopefully you can stretch everything out. And that's the basis of medicine, trying to stretch it out for 120 years. But if you tell me someone's 50 years old, I'm going to say, okay, 10% chance is a liver cyst. Let's just talk about the abdomen. 10% chance is a liver cyst. 8% a splenic cystic lesion or calcification, maybe even higher than 10%. 8%, 7% an adrenal lesion, adenoma. Renal cysts, half the patients. Renal calcifications, 20% of the patients, maybe. Diverticular disease, osteophytes in the spine, all of those things, a little degenerative change in the hips, maybe degenerative change at L5S1, all of those things are indeed common. That's not abnormal. That's just normal. And so when people did whole body screening, they would say, well, 70% of the patients they scanned who were well patients were really abnormal. That's madness. When Karen Horton and I did the whole body screening at Hopkins, we did it, I think, the right way. It was 3 or 4% were positive. And when we said positive, it was positive. We weren't calling every plaque, every little nonsensical thing to be important. So when you're reading a scan, you got to think of it that way. And there have been many articles that make this point. So let's take adrenal, first of all. 4 centimeters, well-defined, surely under 10 Hounsfield units, but regardless, it's most likely without looking at adenoma, an incidental finding. Yes, you will pick up incidental pheochromocytomas, but they're vascular and they're higher density. Yes, people do get metastasis, but invariably the patient has a known primary. And if they don't have a known primary, you're going to find something. So that's the thing. If I just see an adrenal lesion, it's going to be an adenoma. There have been articles about this many, many times. If I see a splenic lesion, yes, you can have lymphoma. Yes, you can have melanoma, metastasis. Yes, you can have abscesses. But all of those are patients are symptomatic. You occasionally pick up primary lymphoma of the spleen. You pick up mets, but the patients have symptoms. Patients who have splenic abscesses are febrile. They're sick. They're just not coming in there because they got a scan for some right lower quadrant pain or something. So you want to think of it that way. Diverticular disease, you know, it's an American disease, perhaps. But a lot of people have it. Some people have it the whole colon. Most people have it in the sigmoid colon. It's a little bit, not so bad. Degenerative change in the spine. Maybe you ran too much. Maybe you have hip pain. Again, the same basic principle. So we need to really think about what we see and how often we see it, and that becomes very, very critical in how we do things. Okay, so just think about things that way. The same thing in the liver. The challenge is most liver lesions are going to be benign as well. Liver cysts, hemangiomas. Cyst water density well defined, hemangiomas peripheral enhancement. Things break down, of course, when people have a known malignancy, and then you worry more. And that's what people get into the thing about, well, if lesion's 5 millimeters, probably okay, but too small to classify. And it's true, these 3 to 4 millimeter lesions are hard to classify. They're just too small. But if I don't see a perfusion change, I'm going to go with likely they're probably a cyst. And surely if the patient has no malignancy, I'm not going to start up saying, can't rule out an occult colon cancer. Okay, that becomes very, very important. Scan protocols are also important. If you give the patient water or positive contrast to drink, the stomach's distended, and you're not reading every patient as I can't exclude a gastric primary or gastric mass or something of that sort. If you give the patients water or positive contrast, you get a good distension of the duodenum. If you give IV contrast routinely, you're going to get good enhancement of the liver and spleen, and those little lesions are better defined because they're cysts or hemangiomas. And the small cystic pancreatic lesions, which most of the time are benign IPMNs, you're going to see as well. Now, you don't want to overcall. Same thing in the kidney. Most lesions are easier to see when you have good visualization of the patient's enhancement patterns. So we talk about neuroendocrine tumors, we talk about cysts, we talk about adenocarcinoma. Sometimes you can pick up the lesions without IV contrast, but many times you can't, and surely you can't classify. And again, pancreatic cysts are not uncommon. They seem to be more common. I don't remember them in the past. And perhaps part of it is the fact the scanners have gotten better. When you had old scanners, you couldn't see much. When you have new scanners, you can see a whole lot more. So picking up incidental findings is probably more likely the better the scanner you have. So that indeed becomes very, very important to think about. So I think protocols are really good. I mean, obviously we know protocols are great for lesion detection, but if I have a good protocol, I really feel more comfortable in being able to exclude things. And what we're saying is, when you're dictating, it's more saying, okay, this is an adenoma. Next, don't follow it. Don't get a repeat. Don't get it. This is a hemangioma. Don't worry about it. This is splenic lesion, probably hemangioma, hamartoma. Okay, we don't worry about that. Diverticular disease, we don't worry about that. The granulomas in the lung, those 2 millimeter lung nodules, which the residents read all the time, you don't want to be calling those. Could this 2 millimeter become a cancer in 20 years? Okay, it's possible, but in the right population setting, half the patients have small granulomas. And many times what they're pointing out as granulomas is not even a granuloma. It's simply a vessel on end. And as scanners get better, and particularly if you use MIP imaging, you can use and basically create a scenario where everybody has a lesion. Same thing in terms of adenopathy in the chest. Small nodes under a sonometer, pretracheal, subcarinal, hilum are just small nodes. They have no clinical significance. If you have a malignancy, if you have lymphoma, if you have metastasis, the nodes are larger. They're usually over 2 cm, surely above 1.5. But granulomas disease is very common in a population, in any population in Baltimore or any place else. Tiny little ditzels that are near the pleura, usually the scars, old infarct, old inflammation. And particularly in oncology patients, people start calling those as important. They're not important. They're scars. Nodules are nodules. Mets are mets. These are not nets, and these are not nodules. They're just simply scars. So that indeed becomes very important as well in that regard. Now, the same thing in thyroid. You know, a high percentage of patients have tiny thyroid cysts if you look hard enough. Can you say it's not a cancer? But if they look like little tiny cysts, we describe them, but most of the recommendations are just follow. Don't even follow them. It's a simple cyst. You know, you do more harm by following them, by biopsying them. Patients have all sorts of issues. You don't want to get into that scenario. That indeed becomes very important. So again, you want to know what the range of normal is, and perhaps that's a better way of thinking about incidentalomas. What's the range of normal findings? Not mint condition, but a normal 50-year-old or 60-year-old or 70-year-old. Same principle, coronary artery calcifications, Frequency increases with aging, no problem there. Frequency of vascular calcifications of abdominal aorta increases with aging as well. So we need to really know what kind of patient we're dealing with and then consider things within that realm. Now, I will say that the talk is mostly over. I don't mean it that way, not that I got to go somewhere or rush, but if people have questions, now's probably a really good time to ask questions. I don't have a lot of questions on my thing here. So people do want to know, in terms of structured reporting, does that have any impact? Structured reporting is good. A lot of people use it. I'm not a big fan of it. But I think the big thing is with structured reporting, you also want to be careful what you're describing. And you can describe a lot, but then in the impression, you don't want to say advise clinical follow-up if clinically indicated. I think the surgeons, the internists, you name the doc, when you start saying these incidental findings, I'm not certain what it means, advise this, advise that, that's probably problematic. The other thing is, there's been articles and we've published them. There's a lot of ACR guidelines. You should look at the appropriateness criteria about what's important and what's not, how to follow things, when not to follow things. I think it's important to also that within your group, if you have 20 radiologists, you don't want to have 20 different opinions. We try to make it that we have one opinion, we follow best practices. The clinicians go crazy when one doctor says one thing and one says something else. Also, make sure you look at old films. I think one of the challenges is not having old films, particularly if patients had scans elsewhere. Old films, remember you were a resident, the first thing they told you the first day was, look at the old film. Something that's worrisome, if it was there 9 years ago, is not really worrisome. And that becomes very important. And we see all sorts of workups for things that are not important. Adrenal masses, 4 cm, 5 cm, 6 cm. Often they're myelolipomas, they're old hematomas, old scans help, looking carefully at the criteria. Understand what you're looking at, what you're looking for becomes very, very careful. Scott makes the point, unintended consequences of screening. No good deed goes unpunished. The problem with screening, sometimes we pick up early tumors. That was incredible. We save lives, pick up early renal cells. But sometimes you pick up things that don't matter. You pick up a papillary cancer, the patient's 75. That tumor may not grow. Some of our urologists follow incidental renal cell carcinomas. So again, what you know and what you don't know often is, you could argue, the challenge of getting everything correct. But it's, again, a strategy. Now, we're never going to be perfect. I'm not suggesting that you simply blow by lesions. That's probably nothing. Sometimes it is nothing. Sometimes it's a high-density renal cyst, and you only have one phase, and you can't tell a high-density cyst from a papillary renal cell carcinoma, and you need to recommend other studies. I'm not saying that's not the case, but I'm saying there are some people, and you know them, they're in your group as well, who can't read a study without recommending 3 other studies. Now, maybe they're good for your volume, get a lot of referrals, but it's not what you want to be doing. Now, I see Michael King has an eponym called vomit. I'm not going to comment on that, but I think it's this balancing act. I think as studies get better, and this incidentalomas thing is true for MR, it's true for ultrasound, it's true for angiography. Every imaging study is true for brain CT, musculoskeletal. And I think with experience, the one thing you tend to do is you look at something and say, that's not important. I've seen a million of them, it's nothing. Residents with less experience will say, hey, I'm worried about this. It'll be interesting as AI gets better. I think one of the challenges with AI will be detection and then management. So AI may be, for a long time, it's going to say, hey, doc, look at this. What is this? AI is not going to tell you it's an adenoma. It'll pick up the pancreatic or adrenal lesion. But at some point, the way AI should work is saying, hey, I've seen this 1 million times, and 999,999, it's benign. I'm calling it benign. Okay, it's an adenoma. No problem. So I think one of the things that's going to be built into AI is this ability to deal with these incidental findings, because if AI in the future makes everything important, there's going to be a problem with AI and the use of AI. So I think that part is really important. So again, recommendations is a few lectures I've given on incidentalomas. We're going to update one probably in a month or so. You'll see it then, but you can look on CTisus for that, or look at our app on the App Store. You could do that. A lot of articles, you can just Google incidentalomas. There's articles on every organ. Again, ACR, appropriateness criteria. There's an article on pancreas. There's an article on kidney. There's an article on adrenal. There's an article on the liver. So every one of these is really going to be looked at with care. So with that, I guess I'm going to give you 10 more seconds to ask any questions. I see a lot of people who I know on, so that's great. But if anyone has any questions, unfortunately, people who are on Instagram, I cannot really look at the questions. Let me see. There's a trick for me to do it, but looks like the phone has died on Instagram again, so I can't do much there. But I'll thank everybody for their attention and have a great day. Today is Thursday, so have a great weekend, and hopefully where you are, it's not too hot. And with that, I'll see you later. Bye.